Good morning, everybody, and welcome to this edition of Edge Talks. Today we're looking at the Maker Movement, a model for healthcare transformation, by Joyce Lee, who's joining us at 3:30 a.m. So we'd like to give her a very special welcome from you all. Dr. Joyce Lee, known as Doctor as Designer, is an associate professor at the University of Michigan Medical School and School of Public Health. She conducts clinical and outcomes research focused on children with obesity and diabetes, leads local and national quality improvement initiatives focused on individuals with type 1 diabetes, provides clinical care for children with diabetes at Mott's Children's Hospital, and applies the methods of design and participatory design through her work at Health Design by .us. So today we're looking forward to listen to Joyce learn about the Maker Movement. Now we'd like you to get involved, and there's multiple ways to do that. We have the chat box, which is in the WebEx software, and you can also tweet us using the hashtag EdgeTalks, and you can also copy in the Twitter handles School for Radicals and the Edge NHS. If you'd also like to join our community, which is on Facebook, please send a request by looking up the School for Healthcare Radicals and the Edge NHS Facebook pages. Today, my name is Dominic Cushnan, and I'll be chairing the session today. On the chat room monitor, we have our lovely Carol Reed, and on Twitter, we have Ollie Benson, who you can follow on Ollie Benson as well. I'm going to hand over to Joyce Lee in one moment, but I also wanted to introduce and discuss about what we're looking at next time's Edge Talks, which is on August the 5th. We've got the wonderful Sue Haynes that I managed to have a wonderful opportunity to listen to her present at Nottingham University Hospital, and she'll be talking about talent management. And on the 2nd of September, we've got our lovely friend Maxine Craig, who'll be talking about culture and change. So I'd like to now hand over to Joyce Lee, who will take us through the Maker Movement.
Hi, thank you guys so much. Can you hear me? Hi. I really appreciate the opportunity to come speak to you guys today. It is a little bit early where I am, but I'm excited to be with my friends across the pond because I think the work that you guys are doing is pretty incredible. So in terms of my goals for today, I want to provide an introduction to the Maker Movement and participatory design and the work that we've been doing as an interdisciplinary collaborative at University of Michigan. And then I wanted to give you some background into the Night Scout project, which is really basically a living example of the power of the Maker Movement. I'm a researcher and a clinician focused again on type 1 diabetes, and so we've been doing a lot of research, including ethnography, survey research, as well as secondary analysis of a Facebook group to try and understand this movement that's happened sort of bottom up inside the type 1 diabetes community. And then I wanted to just open up a conversation with the community around design and making as a healthcare platform. Helen, I just had a chance to sort of look at your slides from your recent talk at Monash University, and I think, you know, sort of how do you move from programs to platforms? I think that was a really interesting and timely sort of discussion around how we design healthcare systems and why I think the Maker Movement is so important as we think about that design. So just to give you a little background, I do want to acknowledge my disclosures. Just again, I am an associate professor at University of Michigan, and I'm a pediatric endocrinologist. And so what that means is that I basically work with children with type 1 diabetes clinically. But I also do health outcomes and clinical research, and a lot of my research is now pivoting more towards implementation science and quality improvement as we're building a learning health system for type 1 diabetes with a national network called the T1D Exchange. And as well, I do work in mobile technology and data visualization focused on diabetes and participatory design and social media. And then locally, I do direct quality improvement for our pediatric diabetes clinic. And that just gives you some background as to sort of where I'm coming from. I do want to make the disclosure that I don't actually have any formal training in design. I call myself Doctor's Designer online. But you know, how could I even have like the chutzpah to say that I can call myself that when you think about people like the man on the left, right, who design beautiful small things like the Apple Watch, right, designing health apps and things like that. But I think one of the messages I have today is around the democratization of design, and that and that really everyone can, should, and think of themselves as a designer, and that's something that we should really espouse as we think about transformation inside our healthcare delivery systems. So I want to tell you a little bit about how I kind of came to my identity as doctor's designer. It was actually a personal design experiment that happened a couple of years ago when I went cross country to spend my sabbatical in the Bay Area and brought my 2 kids, B and S, who have life-threatening food allergies. And so B has actually been to the emergency room a number of times for anaphylaxis to dairy, egg, and peanuts. And so we have to carry around this EpiPen to make sure that we can basically save his life in case he has an anaphylactic reaction. So, you know, when we went over to the West Coast, we brought what the allergist typically gives everyone, right, which is this food allergy action plan. But I would call it a design fail, because this is a really hard document to use to communicate to a caregiver, you know, how to save your child's life, right? And so I was looking around for resources or other tools that we could use, but I just had a hard time finding things. So ended up kind of getting interested in social media. You know, I was in the Bay Area, like it's the home of Google and YouTube and Facebook, right? So decided to actually make a little video. But I call myself a lazy tiger mother because that's my son who plays violin. Both my kids play violin. Not very well, but they play. So, you know, at the time he was 6 years of age and he was just learning to read and write, and I wanted him to be part of this process. I knew that I had to sort of communicate to his caregivers the sort of vital information about how and when to give the medications, but I also wanted him to learn from this so that I could sort of have him protect himself as well as protect him by educating his teachers and his caregivers. So we ended up creating a YouTube video, and you can find it at ihavefoodallergies.tumblr.com. I'm sorry, I can't show it today, but apparently there's no video on WebEx. So you can go to this website. It's our little blog where we have all the information about, vital information about food allergies. And so, and the bottom line is what I did was I scripted it, and I sort of kind of walked through the types of sort of medical content that needed to be in there. But what he ended up doing was he ended up actually illustrating the entire video and then narrating it. And so we did that through a series of basically PowerPoints with like audio clips and then doing a little bit of screencasting. So it gave not only the information about when to give the medications, but it also gave information about how to give the medications and the fact that you have to call 911. And what I ended up doing was putting it online. And so we had just started the school year. We were just starting to educate his teachers. We ended up sharing it with the teacher, and she ended up sharing it with over 700 students and 40 teachers at the local school that they were spending the year at, because they had sort of a video broadcasting system. And then it was interesting because I met up with some other colleagues who are sort of interested in pediatrics and digital health. So for example, Seattle Mama Doc, she ended up blogging about how, you know, this was an example of kind of bringing the food allergy action plan to life. And Susanna Fox, who's now the CTO for HHS, kind of commented on it as a useful educational video. It was interesting because she compared it with Mike Evans, who's, you know, one of sort of the leaders in health communications. But I think she thought it was approachable and effective, you know, despite the production value. So, you know, what can you do with a mom who's not a formal designer with a 6-year-old? But I think, you know, it did its job. And then we actually ended up making a couple more videos because, you know, we ran into other instances where they were like having him make cupcakes but not touch them, but there were all these allergens that he was kind of working with. So we actually made a part 2 video, which was focused on ingredients and food handling, and you can check it out at the blog. We also did, when we got back to Michigan in the fall of the next year, a video about allergies because asthma was acting up, and he didn't have a great familiarity with his breathing issues. And then I even did some of my own making. So this was sort of my initial prototype of when I kind of brought the EpiPens with the kids to the different daycares or to the different teachers. I had to bring some sort of physical kind of sign, and I think that was sort of a failed first prototype, but ended up turning it into, a name tag that has all the information about how to contact us, what the allergens are, QR links to the videos, and then information about specific ingredients that they're allergic to inside the booklet. And so now we sort of carry this around every time we have a bag, a Ziploc bag of like the EpiPens and the Benadryl, and then this is sort of the book that goes with it that basically follows them around wherever they go. The first video actually ended up getting like something like over 2,000 hits by now, and I think that was exciting, right? That was sort of success, but I think the bottom line is that it doesn't matter. It's basically sort of these are the tools that we use whenever we start a new school, whenever we start a new camp, right? We have to have this information, and this was like the best way for us to display it and teach it to the people that care for the kids. And so I don't think I realized it at the time. I was just sort of exploring social media, and I was just trying to, make tools that were actually useful as a mom and a caregiver. But I think, what I realized is that this is really the future of healthcare, right? It's this idea that patients are the experts, right? Like I tried to find videos online. I tried to find educational materials that really suited, or served our needs, and I couldn't find anything, right? So I sort of noticed that there was a problem. And then we were makers, and granted, this wasn't sort of a physical prototype, but this was definitely a digital one, right? And so what we were able to do was, use simple tools like an iPhone to take pictures of the illustrations, PowerPoint, audio clips, some screencasting software, and that allowed us to basically upload and produce online so that anyone could reach it with just the click of a link, right? And then finally, I think that this was a great collaboration between me and myself. I could have made this video with my voice and my illustrations, but I don't think it would have been as effective. And in the process, I think he learned a lot about his disease. And so, I think this really represents how I see the future of healthcare, patient as expert, maker, and collaborator. So, when I got back to Michigan after that year-long sabbatical, I ended up spending some time with some colleagues from across campus, right? So I'm with Mott Children's Hospital, but ended up kind of working with the School of Information, School of Art and Design, really an interdisciplinary collaborative of individuals, which includes, healthcare stakeholders, patients, caregivers, and sort of the tinkerers, the designers, the makers, the technology experts, right, to sort of explore the intersection between healthcare and design. And so we have 3 missions, and we've been doing work together for about the last 2 years, and we have sort of 3 focuses. One is education, and one of our goals is to integrate design thinking into the medical enterprise and to promote the participation of makers inside the healthcare landscape. I think we see that there is great opportunity in bringing people who have skills to make things inside healthcare, which has huge, horrible kind of dysfunctional problems inside it. And then there's great value in taking healthcare stakeholders and sharing their ideas with the tinkerers and the makers who want to make things, but actually want to make things that are important and meaningful and useful to patients and caregivers. In terms of research, we're partnering with patients and caregivers to create opportunities for participatory design, citizen science, and open science research. And so I'll tell you a little bit more about this as I describe Night Scout, which is a community of patients with type 1 diabetes that we've been working with for some time now. So you'll hear about that soon. And then clinically, we're just very interested in providing tools and technology-based systems for transforming patient experience. I think, I don't know if you guys experience this with NAHS, but I think, generally in our system, we're pretty analog in our you know, in our tools and the things that we give to patients, we still print everything out, right? So we really need sort of more up-to-date kind of media and more effective ways to communicate health information to our patients. So, you know, we started out and we continue to use sort of the principles of human-centered design, right, which is an approach that puts human needs, capabilities, and behavior first, and then designs to accommodate those needs, capabilities, and ways of behaving, right? And so it's really learning how to do this process of design, which, you know, starts with empathy and understanding your user, leads to definition of a problem, allows for creative brainstorming, and allows for iterative kind of prototyping and testing so that we can build the right product for the right person. And so I think one of the approaches that we use, so, you know, we will do this kind of in a long extended sort of fashion when we're trying to work on projects and trying to get to product over months or weeks. But then we also kind of go through that process in sort of workshops that we run locally. And a big, I think, point of these workshops is to really socialize design inside a healthcare delivery system that doesn't even know what design is. But one of our guiding principles as we do these workshops and or as we kind of use the process of design to sort of improve patient experience and patient services is really this concept of participatory design. And so it's essentially just making sure the users are in the room and sort of go through the design thinking process and create and co-create with us. I think often healthcare providers are in the room, healthcare administrators are in the room, but people always forget to invite patients and caregivers, and they are the end users in healthcare. And so it is really critical for us to have them in the room so that they can voice what the real problems are, so that we understand the real problems that need to be solved rather than the problems of the doctors or the administrators. And so, you know, on the left-hand side, you have this picture from the walls of University of Michigan Medical School, right, which is sort of the scientists. And on the right-hand side, you have a little girl who I think at the time was 10 years old, and she has type 1 diabetes. Her name is Olivia. And, you know, she was someone that, as we were doing a workshop, you know, her mother, we had invited her older sister, who's an adolescent, and then her mother said, well, should I get a babysitter for her? But we ended up saying, you know what, you should bring her with you, and like we should put you in a group and design together. And she did a fantastic job of kind of getting into the process and helping develop the prototypes and even sort of presenting the prototypes to a large group of academics and students and staff and patients. So I think one of the things that we sort of try and emphasize is that patients and caregivers are the real experts in healthcare. They're the patients that sort of live the experience, live with the disease, and understand it in a much deeper way than any clinician or healthcare stakeholder could. And so one of the things that we do when we bring patients into the room is that we give them name tags that say expert. And now we actually say expert/designer, because what we want to try and kind of create is this culture of respect and understanding that they're probably the smartest people in the room. So we've done a whole bunch of different interdisciplinary design workshops, and what I've tried to do is, as a really busy person, try and sort of multitask and or insert design into all sorts of opportunities that exist, right? And a lot of that comes with just kind of boring, quote-unquote, committee work, right? But, you know, if you're doing a patient educational advisory committee meeting, why wouldn't you turn it into a design workshop if you have stakeholders coming to give their input, right? We've done some educational workshops focused on the resident sign-out process. I mean, we really basically just take whatever opportunity we can, like in the operations of healthcare, to use design thinking and insert it into that process. And then we've also tried now to sort of formally do some of this workshopping and or collaboration by integrating with students who are doing curricular programming with School of Art and Design and School of Information. So for example, we have a mini grant for the provost where we've been working with, for example, Nancy Benovich-Gilby. She runs the entrepreneurship program at University of Michigan School of Information, and she was running a Swift iOS programming course. Matt Kenyon was running a digital game design course. And so what we do is try and integrate patients and caregivers into the curricular process. So in the end, the students have to make prototypes, but what we did is we did a kickoff workshop where we introduced them to a variety of different patient and caregiver stakeholders, went through the design thinking process in a couple of hours, and ended up sort of pairing up students with specific clients, quote unquote, patients or caregivers to develop prototypes as part of their academic work. And so there's great value because, one, they need real problems to work on, right? Things that go beyond sort of what might be replicated in the App Store. And then patients and caregivers, and I think the healthcare delivery system, there's not a huge investment kind of locally in mobile technology and or any sort of technology. So like having the opportunity to work with makers or tinkerers who can sort of take your problem, turn it into a prototype and turn it into something, and to help work with you to design it, I think is a really powerful experience for the patients and caregivers. And then we've also just done sort of pairing up of patients and caregivers with students in sort of more kind of internship opportunities to get them to sort of create and work together. So just briefly, either long form or short form, what do? We make sure that we understand a problem before solving it. And again, it's so critical to have the patients or caregivers in the room when this happens because they will articulate problems that are very different than what the healthcare stakeholders would articulate, right? We want to make sure that it's actually a patient-defined problem. We recognize that in sort of care delivery systems, there's sort of priorities and competing issues, but I think we sort of use we're very interested in sort of letting patients drive this and sort of letting the process of design be a little bit more arbitrary. Like if someone values this, then that's important and that's something that needs to be addressed. As opposed to what you might think of as the average problem or maybe the problem that comes from a different perspective, like the healthcare system perspective. Ideation is really important, right? So doing collaborative and creative brainstorming, and that's trying to be visual and sort of creation, but also just creating constraints that force you to come up with a number of solutions, right? We always spend so much time on PowerPoint and on Microsoft Word and like sitting in meetings. And so, the ability to sort of just work with people who are kind of interdisciplinary, who have different backgrounds, and be forced to come up with, 5, 20, 50 ideas that really creates, I think, the opportunity for more interesting and better prototypes or solutions. Prototyping, so we don't tend to do any building inside the healthcare delivery system. So I think that's just, as I'll get to it, making or creating, I think there's something really satisfying about that. So that's part of the process. And then obviously sort of trying to do iterative testing with users to try and improve the prototype over time. So this is just an example of one of the ideas that came out of one of our workshops. So you can go check it out. It's diabetesmoticons.com. But what ended up happening is there was an adolescent, Reese Omer, who was sitting at our table, and she was our patient or client. And then there was this group of interdisciplinary stakeholders who were sort of going through the design thinking process to understand what her issues or needs were with regard to her type 1 diabetes. And so she ended up describing sort of the tension that occurs when she's trying to communicate blood sugars to her mother, because they're doing a lot of texting back and forth with numbers, and I think it just causes a lot of stress. And so the group came up with this idea of diabetes emoticons, right? So then after the workshops, we actually kind of worked with the family to kind of think about what are the different icons they needed for communication. We worked with some designers from School of Art and Design to help design some of the icons, and then we were able to get the Michigan hackers to basically build the iOS and Android apps for free for us. And so I think what's interesting about this prototype is that, I'm a diabetologist, right? And I might have said that my patients need like more diabetes logging apps, right? But if you look in the App Store, there's like 1,000 of those things and nobody uses them, right? And so I think, again, this is a great example of how the right problems get articulated by the right users if you focus on them. And when we did the release a couple months ago, I think we had something like 2,000 downloads in the first 2 weeks, and that wasn't even with a lot of sort of outreach or, I guess, marketing. So I think I think to date we have something like 5,000, and so I think what this speaks to is the power and the uptake of patient design. And so this is sort of one of our first, I guess, physical prototypes from some of our collaborations. We paired Trevor, who has type 1 diabetes. He was a student at the University of Michigan, just in the arts and sciences, but he calls himself the type 1 diabetes evangelist, and he's really got a really positive attitude about having type 1. So we paired him up with the comic book artist, Jake, and they ended up creating this really interesting comic book that you can find on our website called Health Design by Us, where, they talked about where he basically does kind of multiple panels of the upsides and downsides of diabetes. And again, I think this is a really important narrative. It's a gorgeous comic book, and it's an important, I think, educational tool to share with our patients around sort of the social living with diabetes, which is, different than the mechanics of it. And again, I don't think any healthcare provider could have come up with the type of narrative or the beautiful design that came out of this collaboration. And then these are just some of the examples of tools. So we've been working with, again, students from School of Art and Design, and then students from School of Information to try and develop more technology-focused applications. And so, for example, the one at the top was an app that helps guide people when they're sick and have type 1 diabetes. Sort of there's, issues around trying to check for ketones and knowing whether you're on a pump or not. And so we originally inside our clinical group, there was talk about whether we should be making a magnet, but the magnet was going to cost $20,000. So we ended up, so I sort of took that nugget and sort of fed it to our colleagues over at School of Information. We were able to come up with this prototype, and we'll probably have many more of these kind of morphing soon, focus on a whole variety of management issues related to diabetes. But again, just trying to bring technology and to bring beauty into the tools that we provide for our patients. So I think one of our critical missions is to move from this concept of design as a distraction from health, right? We have child life experts in our children's hospitals where they engage children with art projects to sort of distract them for their illness. But I think what we're trying to say is, design is a critical tool for the creation of health, and it's something that we should espouse as a healthcare delivery system to really create innovative products and services that really work for our patients and their needs. So as we were sort of doing a lot of this design/participatory design work, I want to acknowledge my colleague P.F. Anderson, who is an emerging technologies librarian at the University of Michigan inside the medical school library. And, I was aware of makers, but I think, she was sort of one of the key people that sort of introduced me to a lot of the sort of local makers inside the Ann Arbor community. But the maker movement is this movement that's gaining a lot of interest, both locally but also nationally. So at least in our nation, it's something that's really being espoused by the White House, by the National Science Foundation, by even the National Institutes of Health. And it's this idea that, and so what is it? So it's actually a movement that is a do-it-yourself technology movement. And so the idea is that everyone's a maker. You learn by doing. So you create things yourself, right? And then there's this notion that the learning is really peer-to-peer. So for example, if you build something, you work with individuals inside a makerspace, like MakerWorks is just one of the kind of local places that's in our region. That's basically a place that has a lot of different tools where people can sort of rent them, use the tools and or share ideas or learnings, and or They can sort of meet up at maker fairs, which are basically kind of congregations of different makers who basically do a lot of show and tell and share what they've learned, share knowledge, share tools, share ideas. And so there's a lot of sort of wacky things that have been kind of created by makers, right? So there are some really hilarious examples. So this is an example of a 80s VCR machine that was converted into a cat feeder. I think the making that most people are familiar with is, you know, the quote-unquote 3D printer, right? That has been used to make some really innovative healthcare products. I think one at University of Michigan was sort of an airway stent for a little baby that was sort of that was kind of individualized and individually made for a little child who had sort of collapse of his airway. Enable on the left-hand side, that's the group of individuals that basically does 3D printing for prosthetics and does it at very low cost by sharing the designs and creating a community of makers who want to make these products with and or for other patients or caregivers. And then there's even sort of more wacky things, right? So I love this. You could even, you know, take a photo of your face and then, you know, get it imprinted into the foam of your latte. And then there was actually a mini maker fair at Ann Arbor, and I thought this was hilarious. So there's this machine called the EggBot. So basically, you can take a picture, it'll draw the profile or image of the picture onto a ping pong ball. So fun stuff, maybe a little frivolous, but I think part of this is the idea that it's fun to do. It's about tinkering, it's about learning, it's about sharing, and so so that's part of sort of, I think, the socialization of sort of the technology adoption. And you know, you can do, and almost anything can be makers now, right? There's DIY electric cars now, there's DIY drones. But I think part of the power of the maker movement is just sort of the mindset, right? It's this idea that, quote unquote, being a maker is not taking the world as it is. So Dale Doherty is, he's like one of the founders of Make Magazine, and they sponsor a lot of the national maker fairs. But it's just this idea that, like, you know what, I can fix it, I can do it, I can build it. I'm not going to accept the fact that no one's made it for me. And then Chris Anderson, who used to be the former editor of Wired, you know, basically talks about the idea that, you know, it's a movement that's democratized technology, and when you do that, you really kind of liberate the ideas and creativity of the population. And so we saw these links between the maker movement and participatory design, right? Do it yourself, patient is expert, learning by doing, patient is maker, and peer-to-peer learning, patient is collaborator. And so we, in the last couple of years, have held a Make Health Fest, which is sort of our kind of health-themed maker fair at University of Michigan for the last 2 years. And we've really, I think, pivoted toward trying to do more making that's within the community. We've been lucky to have some leaders kind of come to our events and help kind of share the importance, as well as like share their knowledge. So Jose Gomez Marcus and Anna Young from the MIT Little Devices Lab, they're spearheading the Maker Nurse project, which is putting maker spaces into hospitals across the U.S. and creating a community of nurses that is encouraging them to sort of create or make tools for healthcare delivery. And then Susanna Fox, who is the Chief Technology Officer for HHS, and she's actually spearheading during her time in the administration the Invent Health Initiative, which is really just trying to create or trying to help the U.S. government create a platform to encourage the maker movement inside healthcare. And so in follow-up, you know, we've done, I would say, more programmatic work in that we're trying to do more design maker workshops focused on diabetes education. We're trying to get patients to help us develop prototypes and turn them into sort of videos / artifacts that we could use to do more tactile and design-based learning as we educate new patients with type 1 diabetes. We've also sort of reached out to community groups. So JDRF is a national group that has a large community of patients and caregivers of type 1 diabetes. But we're lucky to have a partner in Amy Omer, who is a local mom of 2 kids with type 1, and we've been doing a lot of, I guess, design maker workshops in which we're trying to get kids to sort of use the design thinking process and help us develop ideas for prototypes that need to be made for diabetes management. And then we're even trying to do some work in participatory game design in diabetes clinics. So we've been partnering with GameStart, which is a local startup that does that basically teaches kids how to program, but they do it through the medium of games. So one of the sort of quintessential examples that my son has been to is the classes that allow kids to sort of play Minecraft, but on the right-hand side, there's a mod that allows them to sort of program in Python and then sort of play the game by programming. And so we're trying to sort of take that model, but then introduce it into diabetes clinics. So we've been doing some prototyping of participatory game design. We're actually trying to build a diabetes-specific game with the input and participation of patients, and then trying to make it a little bit more of a peer-to-peer experience where kids can sort of interact with each other, learn from each other, because I think that's really important with regard to sort of peer-to-peer support and psychosocial management of diabetes. So, you know, some of the insights I think that we've developed or that we've learned along the way is first that we're all designers, right? Patients, caregivers, healthcare providers. And I think it's not about having a black turtleneck. It's not about being sort of an anointed designer. It's this idea that we all, as people who live inside the system, understand that there are huge problems that need to be solved, and who better to understand them than us, the people who live inside the system. 2, we really believe in this idea that we have to design with and not for patients. You have to bring them to the table. If their voice is not in the room, you are not going to come up with the most creative, innovative solutions, and you're probably going to actually address the wrong problem. We've tried to make design part of our workflow, so whatever it is, committee meeting, educational workshop, like design thinking, I think it's an essential tool for healthcare providers, for clinicians, for patients and caregivers. So how do we sort of get that as a tool that we use, just like any other tool, just like any other method, to do our work more effectively, but also do it, I think, with more of an optimistic outlook rather than a pessimistic outlook, which seems to pervade healthcare these days. I've been amazed by the opportunity to design with members of a different tribe, meaning the technologists or the designers, because you know, in hospital IT, every time you say you want to do something, they basically say, no, you can't do that. You can't do that, right? But it's really incredible to work with partners who say, oh, yeah, I can build that. Oh, yeah, like that's totally easy. We could definitely do that, right? So that has been really gratifying. And then I think the maker movement is a really fascinating sort of, I guess, extreme version of participatory design that I want to tell you more about. And I'll tell you about it through the lens of the research that we've been doing with the Night Scout community. So again, we've been doing research all at the University of Michigan IRB about this project, and we actually published a commentary in JAMA recently with some patient partners from the Night Scout Foundation, so you can learn more there. But just to give you the brief rundown, so this is John Kostick. He is the dad of a son who developed type 1 diabetes at age around 3 or 4. And so when he was first diagnosed, he ended up getting a continuous glucose monitoring system. So this is an FDA-approved device. It's not kind of widely disseminated. I think in sort of other countries, it's not even necessarily covered by insurance. In the US, it's probably about 11% of individuals with type 1 who use this. But essentially what it does is it gives you a reading of blood sugar every 5 minutes as opposed to 4 to 5 finger pokes a day. So it really gives you a much deeper window into the trends and when someone's going to go high and when someone's going to go low. So I think it's become a really essential tool for our patients who are trying to live with a disease that's pretty labile in terms of glucose levels. So he in 2014 or 2013, he actually got this device. But the interesting thing is there was actually no way for him to get the numbers while his son was at daycare and he was at work, because this receiver had to be with the son who had the sensor under the skin. And there was actually no mobile technology solution that allowed him to capture that information from afar. So he's a programmer, and what he ended up doing was hacking into the CGM and attaching it through a USB to an Android phone, and he created the code that allowed him to basically pull the numbers out to an Android phone that could take the numbers to the cloud. And he ended up, now that he got the numbers to go to cloud, he ended up actually creating a whole bunch of tools, including a wearable, so a Pebble watch that will allow him to sort of see the trend in number in real time, a mobile phone notifications, and then even like desktop care portals where he and his wife and nurses, school nurses, could basically upload information about glucose and upload information about like finger prick glucose and insulin doses and carbs, in addition to sort of having the real-time blood glucose stream. So what's interesting is that he ended up posting this on Twitter, and so there were some other individuals who saw this, and they were kind of techie kind of programmer types within the community, and also had kids with type 1 diabetes, and they said, oh my gosh, like, I want that, I need that, right? So he, you know, there were individuals who found him either through Twitter or through blog posts. There was even an individual who was sort of not so techy, so ended up going through elance.com to find a contractor in India to try and help build his own kind of do-it-yourself mobile technology system for monitoring blood sugars. And it's interesting. So apparently the contractor said that the job was too simple. He deployed it, and he just said, pay whatever amount that you'd like to pay. And so what was interesting is that he posted about this on social media, and then there was another woman on Facebook who saw the post. And so this individual talked about the fact that how she, you know, also wanted to have access to this information or to have access to this tool, but she didn't necessarily know how to build it either. So he actually connected her with his contractor in India, and she actually got the system for herself. So began, I guess, the bottom-up network of early technology adopters inside this do-it-yourself diabetes community. So there's a ton of individuals in the community that worked sort of tirelessly to allow this to spread to a much bigger group of families, because everyone who used it found it to be so useful that they just felt that they had to share it with others, right? Because it was really compelling and powerful for them, and really liberating for them, because now they could, you know, go out on date night. Now they could let their kids go out for sleepovers. You know, they felt a lot of improvements in quality of life, as well as opportunities for better management of the diabetes with this tool. And so they ended up opening up this private Facebook group. It's called CGM in the Cloud. It's something that you guys could all sign up for if you wanted to today. You just apply and you can get in. And what the Facebook group did was it linked up to nightscout.info, which is essentially a website that gave all the information about how to set up the system, right? So it gave information about what are the components you need to buy. It gave basically do-it-yourself instructions about how to set up the system for yourself, and gave links to the open source code that you would have to use to set up the system. And then, you know, it's interesting. So there was a hashtag that sort of was born out of this movement called We Were Not Waiting, which is used quite often in the diabetes community. And it was just this idea that, you know, they were not going to wait while we were trying to, as an endocrinologist, to assemble the disjointed pieces of the data puzzle. They weren't going to wait for FDA to come up with the right solution. They weren't going to wait for the device manufacturers to innovate, because a lot of the devices that exist now are pretty primitive, right? And they didn't want to wait. They wanted peace of mind that their kids could be safe, right? And so sort of one of the mantras of the community was like, pay it forward. If you were helped by this technology, then do something for someone else to help someone else. And so this really was sort of a bottom-up kind of community-driven phenomenon. So what's interesting is that essentially what happened is that not only did the Facebook group just serve as a placeholder for people to sort of see the link and get instructions to go to the website, but there was a support group that came out of the community. And so there were basically people who were monitoring and who actually continue to monitor the Facebook page. And primarily it was technical questions about technical troubleshooting for Night Scout, right? So it's basically like Geek Squad for DIY diabetes, but with like basically donated time, right? So a lot of people were asking about what wouldn't work, and people would reply back and give explanations about, you know, how to fix their technology. But then it's also interesting because what's happened is that people are just sharing all sorts of things, like advice about general diabetes technology and what types of, equipment you should use and what's useful. They give information about how to manage skin rashes with the devices that individuals are using. People are even kind of providing insights or help around blood sugar patterns and management, and then how to deal with kind of policy issues, whether it relates to school nurse or working with endocrinologists and or working with insurance to cover some of the devices that are desired. So this is, I think these are some of the memes that have come out of the community. There's some great ones that get posted in the group all the time. But, it's just this idea that I think, patients or families, I mean, most of the individuals who use this are parents of younger children with type 1 diabetes. That's what we found in our research. But, you can let your kids go to the beach because you have peace of mind because you understand what's happening with their blood sugars while they're, far away from you. And I think this is my favorite example because this is like truly CGM in the cloud. So this is a map of people who've decided to sort of identify themselves as users of Night Scout, and I think it's fascinating, right? Because what came out of a simple Facebook group that might have originated in the U.S. has spread to a global phenomenon, and there are people all over the globe using this technology. And I think this is really, a great example, I think, of what you guys inside the EDGE community are trying to sort of propose. And it's this idea that, like healthcare is no longer delivered through the walls of the healthcare delivery system, right? This is something that's been absolutely driven by social media, and, it's people adopting and finding out about tools, technologies for managing their disease that are that have no boundaries globally. So there's actually now 18,000 members in the U.S. CGM in the Cloud group. There's another combination of about 7,700 individuals in the international group representing 28 countries. And so these are the different countries that actually have their own Facebook Night Scout groups. And the bottom line is that it was created because there's so many people inside the Facebook group now that when you post, it immediately just disappears because there's so many people inside the group who are posting. And so these local groups were created to sort of create more local communities around the larger community using the technology. And so now there's over 25,000 members in over about 2.5 years. So these are just some of the country groups that have their own Night Scout communities. So, in terms of like our ethnography, obviously open source code was a big piece of the innovation of this, right? What one person knows, everybody knows, so it's traveling at the speed of light, right? And sort of that openness, that transparency is a really important piece of why this has spread so quickly. And essentially, this is a great example of a collaborative innovation network, right? Which is, a cyber team of self-motivated people with a collective vision, right? Enabled by the web to collaborate in achieving a common goal by sharing ideas, information, and work. And so these little organizing units have basically sprung out of this larger community, right? So now there's a leadership team. There's a foundation that's trying to sort of take the pay it forward spirit of the community and do some more formal work with the community through formation of a formal nonprofit. And they're the group that we're partnering with to do a patient-centered research collaborative innovation network. There are patients who are in the community who've interacted with FDA, and I think this was the first time that patients had really directly interacted with FDA around the technology. So that was a milestone, and there was actually some thought that the conversations and the Night Scout kind of happening of Night Scout probably might have led FDA to sort of approve the mobile technology versions for the continuous glucose monitoring systems much more quickly. There's a core development team, right, that continues to update the code, add new features into the sort of the standard recipe. And so they started with 10 features with apple pie, which was their first version, and now they're at funnel cake, and there's now 152 features. I think that happened in about 1.5 years time, right? So talk about, I think, innovation or technology innovation among this group of individuals is pretty incredible. And then there's a support team. So there's people in the U.S. who are basically like answering support calls on a regular basis or support posts inside the Facebook group to help individuals with their setup. And what's interesting is when they go to bed, apparently there's another group of individuals kind of on the Australia, on the other side of the globe, who get up and take and do that support when the U.S. people go to bed. And then people are also doing sort of meetups, right? So they'll sort of pick diabetes meetings like American Diabetes Association or Children with Diabetes, and then there'll be a bunch of volunteers from Night Scout who will kind of do a meetup alongside those meetings to help individuals in person do support and or kind of help set up systems. And so what's interesting is that you would assume that so the group started in April 2014, and now we're kind of in June. So this goes for more or less the first 2 years because this goes until April 2016. And so what this is sort of secondary data from the Facebook group that we were able to download as part of our research IRB. And so we are counting new members. We don't know exactly like when people join, but we're able to figure out when we make an assumption that the first time they make a post is sort of the first time that they join, right? And so you can see there's this peak somewhere around July, August 2014, where people started hearing about this. There was a lot of new members joining the group, so this is sort of incident members inside the group, right? And then in March, April, May of 2015, the commercial solutions started drifting in, right? So the actual FDA-approved app that went with the continuous glucose monitoring systems, they started getting approved, right? So you can see a little bit of a dip where perhaps there's a little bit less adoption because now the commercial systems exist. They're probably easier to set up. So people might sort of use those systems as opposed to the do-it-yourself solution. But what's interesting is that there seems to be continually new members, even beyond that point. You know, you might say it's the end of Night Scout, but what I think is really interesting is that Night Scout has, you know, basically spawned a maker movement inside the type 1 diabetes community, right? So when you get the commercial solution, you just get one kind, right? But with the Night Scout solution, you have a number of different opportunities to combine different technologies, combine different brands of devices, right? There's an infinite variety of like Android versus iOS, Dexcom versus Medtronic, right? All sorts of kind of opportunities for mixing and matching. It's almost like modular design, right? There's a ton of interesting watch faces that have been developed, and I think those are really interesting because I think they're sort of fascinating designs that end users have created that serve their needs. So perhaps these should be sort of the watch faces or innovations that should be used by the companies in the future to try and you know, create more user-centered products. And there's also new ways of thinking about the data, right? So there's an individual, Brandon, who has his blood sugar alongside the temperature, alongside the bus route, which I think is sort of an interesting way, an ambient way of thinking about your blood sugars instead of it being sort of something that's really in your face all the time. And then people have even developed, you know, watches that can tap into Night Scout even while you're camping and you don't have an internet connection. On the left-hand side, there's an individual who was a super techie who ended up making a menu bar for his Mac where he could display his numbers. And then people started developing either other things like 3D printed cases to hold the Android phone close to the receiver, so that because there was sort of breakage that would often happen, and so this kind of kept the technical system stable. Now people are basically innovating on the hardware side too. So they're actually developing their own receivers that are reading from the sensors that people are using that are FDA approved. And the rig has gone from sort of a tackle box size to something that actually fits inside a Tic Tac box. And you know, the makers are now actually moving into do-it-yourself artificial pancreas as well. So they're actually developing, so this is Scott LeBrand and Dana Lewis with help from Ben West, who was sort of originator of some of the code. They're developing their own artificial pancreas systems, none of which are approved on you know, in the commercial side, and there's a lot of companies who are pursuing the artificial pancreas solution kind of officially, right, through the regular enterprise channels. But what I think is interesting is that people are saying, you know, I don't want to wait any longer. I need these tools now to help manage my diabetes, and they're getting really incredible results in terms of their glycemic control and improvements in the quality of life. And so this is OpenAPS. This is the DIY artificial pancreas system, and they actually presented at the San Francisco Maker Faire this spring. So, total meeting up of the makers, right? This is a critical example of Night Scout is a critical example of maker movement inside healthcare. And then, we've done some survey work to try and understand the impacts on health outcomes. And I think there's a lot of people who may be skeptical about quote unquote rogue elements inside the diabetes community, making these do-it-yourself tools that are not approved. But what's fascinating is that people are reporting really incredible results. And then this is self-reported data before and after use of Night Scout. So it's obviously a select group and it's a social media group. So there's a lot of issues with quote unquote generalizability, but I still think this is quite dramatic evidence of the potential benefits of having access to the technology and being able to use it. So Night Scout is a critical example of a maker movement for diabetes, right? Patients and caregivers are really the lead innovators. They are driving this model for personalized medicine as they're choosing their devices, their wearables, their mobile apps, their interfaces, right? Figuring out what tools are right for them and building the system that works for them. And then the third piece is just the fact that, they were doing sharing of open source code through GitHub, and they were doing sharing of knowledge through social media, and that's really helped propel the movement globally, right? And so this is a lead user community. They may not represent the bell curve of patients that we see in type 1 diabetes, but I do, like Eric von Hippel sort of talks about the lead users as like a source for important innovations later on in product development, right? He's a professor at MIT, and I think this is a prime example of that, right, of a lead user innovation community. And so the question or the challenge for us is how do we translate this knowledge to research and care delivery? And so I'm going to kind of close out with just a couple comments about design and making of a healthcare platform. I think through sort of the journey that we've taken in trying to explore this intersection between health and design, I think there's, it's interesting because there's a spectrum, right? So at one end you have sort of professional design, right? So you have people who are certified as designers, perhaps like it's an IDEO, perhaps it's a design firm, right, who are sort of trained formally in design, right? And then you kind of move towards human-centered design. So human-centered design is like a focus on the user, but perhaps it's more as user as object, right? So, sort of professional designer will come in, will do a lot of user-focused research, and can come up with products, but it's sort of this idea that that the professional designer is still sort of driving the overall sort of design, I guess, agenda, right? And then there's participatory design. And so participatory design is sort of allowing users to be part of that human-centered design process, right? Like having stakeholders co-create and work with some of the quote-unquote professional designers to help develop the solutions. And then finally, at the very end, there's this idea of the maker movement, right? And it's this idea that we're all makers or we're all designers, right? And we can create whatever it is that we want if we're enabled by tools and technologies, and we can create our solutions without necessarily the help of others, right? And so, and that kind of brings in this whole concept of meta design. So, I think generally healthcare delivery and biomedical research, it's totally shifted, right, to this whole idea of professional design or not even thinking about the user inside healthcare. But I think I've, through sort of the work that we've been doing, moving more towards the right-hand side and sort of witnessing what's happening inside the type 1 diabetes community with Night Scout and the maker movement, my focus or my idea of how to sort of create innovative healthcare systems is to maybe move to that quote-unquote meta design model. And so, so I've been spending a lot of time with colleagues from School of Information, and so they come from a background of human-computing interaction. So they introduced me, Mark Newman in particular, introduced me to this individual named Gerhard Fischer, who basically talks about, has written a lot of papers about meta design, right? And it's this idea that you're trying to design systems assuming that all of the users inside the system are designers, right? So it's called design for designers. And so users are co-designers and co-developers of the system. And then the meta designers design systems explicitly for evolution. So they make the assumption that our first model is going to be okay. It's not going to be great, but we're going to work with our users inside the system to make it better. And so there's this, so it's not a fixed system. It's a totally changing and iterative system that's really shaped bottom up by the users. And there's a link there to the paper where you can learn more about it, but I think it's fascinating. You know, and so like, what is an example of this? So I don't know if you guys are familiar with Scratch, but it's, you know, it's a tool that's come out of the MIT Media Lab. It's something that my kids use, but essentially it's a computer programming system that's totally democratized design, right? So what it allows kids to do is create scenarios, create games, create movies or videos. But what it's done is it's kind of given them these Lego blocks, allows them to sort of, in a modular way, combine the blocks in any combinations they want to create essentially like an infinite number of prototypes and or products or outputs they want to make, right? And I think it's a really interesting and fascinating model for healthcare. Like, why can't we have a Scratch for healthcare, right? And so they talk about this in education, right? And they talk about how digital fluency should mean designing, creating, and remixing, not just browsing, chatting, and interacting. And I think that's really important. How do we create healthcare systems that that empower individuals, right, to become designers? How do we give them the tools and the technologies to be able to design in modular fashion to create, you know, the infinite number of healthcare solutions that we need to develop, you know, models of personalized medicine. And so I'm not going to go into this. These are just some of the quote unquote meta design objectives from Fisher, but I think these are interesting kind of criteria that we could talk about. And so I actually just wanted to, I think, open it up now for discussion because I feel like I've talked for a long time, and it's hard to sort of keep the talk and also focus on the feeds. I think I wanted to shift over to the feed to sort of have more of a conversation. So,
thank you, Joyce. That was absolutely brilliant, and I think we could see from the energy a lot of people have been chatting in the chat and also on Twitter. I'm going to hand over to Kate if she's here to have a chat about what's happened on Twitter and some of the conversations that have gone on. Kate, are you there?
Hi, yeah, I'm here. It's been an absolutely brilliant session. Thank you, Joyce. And from my own personal point of view, I did the design thinking course earlier last year and found it a really creative way to change our traditional approaches in healthcare products, you know, and how we design our projects. And I think that's kind of like reflected on some of the Twitter comments. Gareth was saying, you know, let's move away from traditional MS Office, and I wonder what, and it made me wonder, I wonder what a maker movement project plan would be like. You know, would there be a project plan? How would we get it? And I think that's like one of the questions I would like to almost feed and ask Joyce if, you know, how do we get from product design to final output, and how do we keep the energy going to ensure that we deliver? And if you have any thoughts on that, Joyce.
Well, I think part of our problem is that we focus so much on final products that we don't think about iterative systems, right? So like, and I think that's one of the powers of design and design thinking, is that it's really important to release something, to get feedback on it, and to be willing to change it and morph it over time, right? I think we have this assumption that, like, we're going to decide to do something, we're going to build the ship, and then the ship is fixed forever once we've done that, right? And I think the whole point of design is to say, let's create multiple prototypes. Let's see which prototypes actually are most effective or most popular or most useful to our patients, right? And then let's work on the ones that like resonate the most, so that we focus on the user-centered designs that are useful, as opposed to like the large ships that we build and that no one ever comes to, right?
I agree. I completely agree. And I think there's an opportunity to work with these other communities to actually start testing some of the ideas that people have that can then shape and influence the rest of the system. I'm going to hand over to Carol now. Carol, are you there? Do you want to talk about some of the interesting comments that you're able to synthesize from?
Yeah, thank you, Dom. Can you hear me?
Loud and clear.
Excellent. Yeah, it's been some fascinating chat in the chat box. Really, people giving their ideas about how we can do this, and also what's going on in the UK. And you know, there's lots of movements like We Are Not Waiting, and it seems particularly. And the question really for Joyce is, diabetes seems to be the condition that many patients and citizens are looking at how they can hack the existing technology to make new technology that works for them. Is that seems to be your common understanding as well, Joyce, that diabetes is one of the main conditions that people are looking at?
Well, I think that diabetes is like the poster child for digital health, right? Because there's measurements that people are doing inside their homes, right, which are not inside the healthcare delivery system, right? 24/7, it's like a completely self-managed disease. I see my patients once every 3 months. I see them for like 10 or 15 minutes, but they do all of the management, right? So they understand living and managing diabetes much more deeply than I do. And so I think, and then if you think about it, like having real-time information to blood glucose values allows you to sort of take action in a more proactive way to sort of, you know, reach whatever your goals are, which might include, you know, like improving your glycemic control, right? So I think it's the disease that's there, and it's the disease that's self-managed, and it's the disease where people are already measuring patient-reported outcomes. So it's the first opportunity, but I wouldn't necessarily say that it's like the only one, right? Like I think it's sort of the first disease, and then there are other diseases that will model after it. It's just that our other diseases probably don't have as great patient-reported outcomes that correlate as much to clinical outcomes.
Yeah, no, I agree. And looking at your slides, which are absolutely fascinating, but people are using sort of open source code, and people are coding for themselves, and we're getting younger people very much involved in that. We have all sorts of restrictions in this country about what people can and can't do, and what companies will let them do with the tech that's already there when people are hacking it. How have you overcome that where you are with Night Scout?
Yeah, so I sort of see this as a bottom-up, do-it-yourself culture, right? So as a provider, I'm not going to prescribe it because, frankly, I don't know how I would do that, right? It's basically impossible to. I will refer my patients to it to say, you know what, you should check out this community, you should check out this technology, you should see if it's something that meets your needs, because it's actually something that's, I think, pretty powerful and pretty empowering, right? And I think a lot of the technologies that the users are building are much more advanced in their design and in their execution than what kind of exists commercially. But we're not necessarily saying everyone go out and adopt Night Scout. What we're trying to do is, I think, develop awareness of it, see the power of it, demonstrate the power of the maker movement and or patient-centered design inside healthcare delivery, because it really has made a huge impact inside the type 1 diabetes community. And so what we're trying to socialize is like the really important positive aspects of this. And then the second piece of it is in the work that we're trying to do, we're trying to build a collaborative research innovation network with the foundation and with individuals in the community. So we don't assume that we're going to be able to grab the entire community. We'll probably grab a subset of the community, but what we're going to do is try and sort of use the principles of open science and use the tools of social media, and take advantage of the fact that there's a lot of people who have the technology who are interested and willing to contribute to the community or contribute to research and or help ideate research studies. So what we're trying to do is take advantage of the fact that there's a huge number of users inside the system, deploy that energy and that pay it forward spirit towards patient-centered research, and allow patients and caregivers to drive not just, the conduct and dissemination of the research, but the actual ideation and design of it.
Yeah, I think you've covered that really well. And I think what we can see from the maker movement is about true innovation. It's taking that big leap when actually at one time there might not be all the data to actually support it, but it's about having a real confidence and belief that you can make several iterations, but you can actually make something that will work for people to use and improve their daily life. I'm not monitoring Twitter, but from my Twitter feed, I've got people that I've never spoken to on Twitter before, but people from the STEM community have contacted us, so they are absolutely loving your slides, which I've been tweeting. So it said it warmed their cockles of their hearts.
Yeah, no, I mean, we need STEM for healthcare. We need Scratch for healthcare. Exactly.
So I thought it was really fascinating because they haven't been on my Twitter feed before, but obviously they've picked it up from the pictures that I've been tweeting. So I thought that was really lovely, and I wanted to feed that back to you.
Thank you.
Thank you, Carol.
Dom, it's Kate here. I just wondered if there was time, or if we could ask any questions from the people joining the session today. I don't know if Paul can manage the technology, or if that would be okay. I just thought we might have time if anybody wanted to ask a question. So, Paul, would you like to add in what people have to do now to ask a question themselves? I think it's put up their hand. Paul,
hello, everybody. Yeah, can you hear me?
Yeah.
Perfect. Right, if anyone would like to post a question, if you either post a quick message in the chat or you can raise your hand. To raise your hand, if you see just underneath the list of everyone's name on the right of the screen, you should have some icons, and there's one icon which shows a symbol for raising a hand. If you raise your hand, I'll then unmute you and invite you to speak.
Joyce, whilst we're just seeing if anybody else wants to ask questions, I just wondered if you could tell us what you would say would be the first steps to start a maker movement locally in your own hospital or own healthcare setting.
Yeah, so I think, you know, we don't have a ton of resources right now, so what we're trying to do is sort of capitalize on the fact that there's a community and there's a lot that you can do with the community, right? So we have, I think one critical piece is just to get different people with different skills and different interests into the same room, right? And so, you know, what we've tried to do is we know now from our Make Health Fest, like we know the makers in the area or in the arena, right? But what we have to do is sort of like bring them to the hospital and or make connections with the hospital and demonstrate or start building, I think, local connections to try and do local building projects. I think that's sort of the first thing. I mean, I think it's interesting because I feel like there's a lot of interest in the maker movement from corporate America, right? Because they feel like it's sort of a source of innovation, and so they invest a lot of money into, like, you know, things like Tech Shop and all these like facilities that are expensive and have a lot of tools. But I think a piece of it is just trying to get, I think, people, I mean, to sort of build the culture around it, right? Is to sort of say there are things that we can do, there's people we can work with, and what are the goals that we want to achieve. And I do think that, you know, it can be a little bit dicey in terms of, like, quote unquote FDA versus, or like, you know, regulation, liability, and sort of making. But I think a key piece of this is sort of trying to make sure that healthcare values this, but maybe almost removing to a certain extent the healthcare involvement of it, because I think the piece of it that we want to share is that patients can do this for themselves. They don't need us. They don't necessarily need their doctors, right? So we're not trying to create a dependence on our system. What we're trying to do is say is that, one, we have the ear of the patients, because they do trust us to a certain extent, right? Like, they listen to their doctors. Two, we need to make the kind of introductions or connections. But three, I think what we need to do is sort of create more opportunity for having this bottom-up movement inside a bell curve of the system that doesn't even appreciate the fact that they can create for themselves.
Yeah. I just have a question, you know, around the health element. There's been a movement that's happened alongside the maker movement around the quantified self. And people kind of analyzing the data regularly, not just diabetes. Do you find that that is a route to market for us to engage with that type of market, to have those conversations around those that are early adopters of working with their own health?
Yeah, I mean, I think, like, however you want to describe maker, tinker, or hacker, programmer, like, generally, like, there's just not enough technology partners inside healthcare delivery. Like, we hire a lot of clinical people, we have a lot of patients and caregivers, but we don't have technology specialists beyond IT, which I think is different than people who actually create things, right? So there's sort of a workforce issue inside the systems that we live in. Yeah.
And I would just like to back it up. I think here in the UK, there's also becoming a bit of a digital divide between those that can use technology and use, can 3D print and get all the emerging technologies that have evolved quite rapidly over the last 10 to 15 years, and those that haven't managed to embrace it or keep up with it. So I have a bit of a call out for one of the work streams that I'm working on, which is, we're calling it digital activism, which is around the idea of enabling people to understand that today they have the ability to leverage more than anybody's ever been able to do over the last maybe 100 years to have an impact on the globe, not just local economy. So they can deliver and do things that has a real impact on society just from sitting at home tinkering.
Yeah.
Okay, we have one of the participants who's just put their hand up and would like to speak. So, Mark Outhwaite, I've unmuted you if you'd like to ask Joyce your question.
Yep, okay. First of all, I'm assuming you can hear me.
Yeah, I can definitely hear you.
Hi, Joyce, great. That's brilliant. It's a really great talk, and I've always, the Night Scout project, I've always been fascinated by. You partly answered one of my questions, and that is these sort of insurgent movements have a greater appetite for risk on the basis of the potential personal benefit than most organizations would have. If regulators looked at what Night Scout were doing, especially in the early days, they would have had connections. And there's a question about how people accept risk in this experimentation. The second one is any sense you have at the point at which commercial organizations watching this from afar feel ready to step in and begin to sort of turn your learning into more effective products. So two things: one's about risk, and that tipping point about people saying, "Gosh, well done, there's a market, we can turn this into a product."
Yeah. So in terms of risk, I think that's an individual decision, and I think, for example, the Night Scout itself, it's really just a secondary display to what you might already see on your receiver, right? So in that sense, it's not as quote-unquote risky, right, as, for example, the smaller percentage of patients who are doing the artificial pancreas, the do-it-yourself artificial pancreas. One might imagine that that is actually a more risky scenario. But I think, when you talk to them, they talk about the fact that, there's a bigger risk in not having additional tools to help manage the diabetes, and there's a bigger risk in not having access to more information and opportunities to act. And so I think, when you talk to them, the risk for them, the risk of not acting is actually much greater than the risk of acting, right, and using the technology. So I think that's the first thing. The second thing is that I wouldn't necessarily, I wouldn't be prescribing an artificial pancreas, a do-it-yourself artificial pancreas to my patients, right? But I think what's interesting about the way that they've done this is they posted all the code. It started out with 2 individuals or 3 individuals using the tools for the OpenAPS kind of artificial pancreas system. And now what they've done is they've expanded to about, I think, 80 now, right? But what they're doing is they're actually having individuals build the systems themselves. And through the building of the system, they're actually understanding their diabetes in a much deeper and much more comprehensive way, right? And then what they're also doing is they're doing sort of more peer-to-peer learning around, sharing what they've learned from their experimentation and their, how they tweak settings or how they change things. So I think that it's a really great model for thinking about propagation of self-management tools and using technology to better understand your disease. So again, I'm not going to prescribe it as a provider because I don't know about the systems and I don't know about the risk, but what I can say is if people choose to use it and they sort of join the community trying to learn from it and they build it themselves, I think they would say that the risk is greater to not even use technology. And then as far as I guess innovation and or sort of the enterprise or corporations, I think the diabetes community has definitely taken note, on the corporate side, of sort of the innovation that's happening inside the system. There have been some kind of interactions with some of the kind of key Night Scout leadership group and some of the companies. So I think there's definitely interest in sort of trying to do lead user innovation, thinking about Night Scout as sort of a group of lead innovators who are potentially developing the products of the next decade or the next couple of decades, right? But I wouldn't necessarily say that medical device companies are really pivoted towards patients or towards user-centered design. So I think there's a ways to go in terms of bridging the gap, but there definitely have been interactions, and I think there is interest, although the knowing how to do that partnership, it still remains to be determined.
Thank you.
Thank you, Joyce. And if we have no other questions, do we have any other questions, Paul?
We do have a couple of other questions that people have posted up. Janet Wildman has asked about the costs. How much do we need to test new approaches to design?
That's a good question. I mean, there's multiple costs, right? There's like opportunity costs. There's technology costs. I mean, we don't have a lot of resources, so we, to a great extent, tried to rely on a group of motivated students who are very interested in, one, gaining experience in healthcare design, and two, you know, don't charge us as much as professional designers do, right? So I think it's hard to say, because like every project that we've worked on, I would say like a lot of the workshops are like a labor of love and a desire to sort of continue to infuse design into the healthcare educational and delivery system. But as far as the technology, I think it depends on like what you're trying to build and what you're trying to accomplish.
Perfect. There were a couple of joint questions which are very similar in approach. One from Sasha asking, how do these approaches change your clinical practice? And then a second one from Janet who's asked, how do we minimize risks with the approach?
So in terms of my clinical practice, I think what I would like to do as a diabetes doctor is eliminate the need for clinic, right? And so like I have this slide up here, right, which shows what the current sort of status is. Patients come to see me like once every 3 months, so that's 4 times in a year. I spend 15 minutes with them. They spend some time with a diabetes educator. They're like sitting in a room for 2 hours and then they leave, right? Kind of dissatisfied, don't get a lot of education, don't get any peer-to-peer support or socialization, right? So I think ideally what we should be doing is we should be creating healthcare delivery systems. Like my dream would be like Maker Clinic, right? Wouldn't that be awesome, right? Where everyone came, brought their own little invention or do-it-yourself solution, right? Which could be simple or could be techie, but allows for, one, the sharing of solutions, 2, allows for peer-to-peer interactions, and 3, potentially removes the doctor from the equation, right? The fact that we see our patients every 3 months is really just an artifact of the fact that the hemoglobin A1C, which measures glycemia, is a 3-month measure, right? So the fact that they need to see me in clinic is sort of an artifact of a previous kind of management of diabetes that didn't have access to digital tools, that didn't have access to, you know, every 5-minute blood sugars. And so I sort of see opportunities for changing the way clinic is conducted, and also opportunities for saying, you know what, maybe you don't need as much of a doctor as you need peer support, as you need work with a system with diabetes educators, and to work with a system that kind of creates more of a maker-creator environment inside healthcare.
Thank you, Joyce. And I think absolutely fantastic. I think a lot of really good answers and really good conversation. I think we'll probably end up continuing a lot of this after this session through Facebook and Twitter and other correspondence. Is this your slide, is it, Joyce?
Yeah, so I just wanted to kind of acknowledge all of my supporters, collaborators, and I wanted to share links for my Twitter and my website, the Health Design by Us website, and then we use the hashtag MakeHealth.
This is brilliant. I'm going to take a snapshot of that. Thank you very much. So I think everybody here would like to thank you for getting up so early in the morning, or if maybe you haven't been to sleep just yet, but thank you for joining us and thank you for being so insightful. I don't know if you can just press the next slide for me, or if I can change that. So thank you, Joyce. And for those of you who are still on the line, we'd just like to invite you to our next Edge Talk. As mentioned, it's with Sue Haynes from Nottingham University Hospitals, who's going to be talking about talent management on August the 5th. So thank you, Joyce, and look forward to continuing the conversation.
Thank you. You guys are awesome.
Thank you, Joyce. You too. Thank you. Bye-bye.
Bye-bye.